Okay, so today we'll talk about rotavirus. So the topic was on viral enteritis, viral gastroenteritis, and that's what we're going to do today. So the most common type of viral gastroenteritis is rotavirus. So gastroenteritis basically means, so gastro is the stomach, enterite is the enteric system, which is intestines, then itis means inflammation. So we're talking about inflammation of the GI system. So the most common cause, as we've said, is rotavirus. As I've written here, a nightmare for infants and young children. So as much as it affects adults, it is more severe in infants and young children. Okay. So we start. So rotavirus is a virus that infects the bowels, causing severe inflammation of the stomach and the bowel, known as gastroenteritis. It is the most common cause of severe diarrhea among infants and children. Okay, so that is something you have to know. So if a child presents with severe diarrhea, think of rotavirus as your first differential diagnosis. Okay. The name rotavirus comes from the characteristic wheel appearance of the virus when viewed on electron microscopy. Okay, basically looks like a wheel. The rotavirus is a member of the Reoviridae family of viruses and contains double-stranded RNA enclosed in a double-shelled outer layer, a capsid. Okay, so I think you're done the session on classification of viruses based on RNA viruses, DNA viruses, and then if they're single-stranded or double-stranded. So this one is double-stranded RNA, and it is enclosed in a capsid. Adults may also be infected, but the resulting illness is usually less severe than that in infants and young children. So we have so many serotypes or species of rotavirus, A, B, C, D, E, F, G, H. But the ones that were most common to human beings are A, B, and C. This is the ones that we're really interested in. E, H are in pigs, D, F, G are in birds, I are in cats. So we're interested in species A, B, and C. Then the leading cause of severe diarrhea in children less than 5 of age worldwide. So in developed countries, you can see we have unknown causes, rotavirus, bacterial, then other. For developing countries, we have rotavirus as the main, as you can see this chunk, okay? Similar to developed countries, these are big chunk rotavirus. But you'll see cases of rotavirus are decreasing due to vaccines that are available. Okay. We go to the structure and protein. So for the structure, we said it looks like a wheel. Can you see here? So here are the rotaviruses seen on electron microscopy. So for the structure, the genome of rotavirus consists of 11 unique double helix molecules of RNA. As we said, it's double-stranded RNA, which are 18,555 nucleotides in total. So this is not that important, but it's just good to know. Each helix or segment is a gene numbered 1 to 11 by decreasing size. Each gene codes for one protein except gene 9, which codes for 2. Okay, this is good to know. So what's important to know is there are 6 viral proteins that form the virus or the viron. These structural proteins are called VP1, VP2, VP3, VP4, VP6, and VP7. Okay. In addition to the VPs, there are 6 non-structural proteins, NSPs, that are only produced in cells infected by rotaviruses. So, as you can see here, this is an electron microscopy. Okay, so the small dark circular objects here are gold nanoparticles coated with a monoclonal antibody specific for rotavirus protein. Okay, so here are the rotaviruses. You can see how they are circular. Then for the structure, I think this picture is not clear. I'm going to show you a clearer picture so that you can be able to appreciate the structure of proteins. VP1, VP2 till VP7. Okay. We'll see the functions. Then how they replicate. So here's the rotavirus and here's the host cell. Okay. So first of all, they have to attach. So there's going to be attachment here. They attach into the host cell, and this is mediated by, as we said, the structural proteins VP4 and VP7. So that's what is going to mediate attachment into the host cell. Okay. So after they attach, you can imagine it attaches, then it has to enter into the cell. That's what we call penetration. So when it penetrates, remember we said it has a capsid, isn't it? The outer covering. So penetration of the cell by the virus is going to penetrate this cell, and uncoating of the viral capsid. We said it has a an outer layer, so it's going to uncoat. Basically, it's like getting away from that coat, okay? It's like opening up, okay? Then when it enters, so plus strand single-stranded RNA synthesis. This acts as the mRNA synthesis, which is mediated by VP1, 3, and VP2. So what happens is it is transported inside the cell. Remember, the cell has so many organelles, endosome, lysosomes, you know, the nucleus, mitochondria, all those organelles are in the cell. So what happens is the single-stranded RNA will be synthesized here in this process. So mRNA protein synthesis, and it is mediated by the structural proteins we had mentioned. So VP1, 3, and VP2, okay? Now, after synthesis of the single-stranded RNA, there'll be formation of the viral plasm. So similar to a cytoplasm, it is the fluid, okay? Then viral RNA packaging, they'll be packaged, and minus strand RNA synthesis and formation of double-layered virus particles, okay? Okay. Then we have virus particle maturation and release of progeny virions. So after the process of mRNA protein synthesis, where the single-stranded RNA is synthesized, it has to be released. So viral plasm has been made, then it is released. So these are the replicated rotavirus. Okay, here they are. Can you see them? So enterocyte basically means this is a cell lining the GI tract. Okay, and here's the nucleus, that like that. Have you understood how they replicate? So there's attachment, then uncoating, then it goes synthesis of the single-stranded RNA mediated by the viral proteins, then formation of the viral plasm. Then what happens is proliferation occurs. After maturation, they are released. Then they go infect another enterocyte, another one, and that's how they replicate. Okay? Have you understood? Okay. Yes. So yeah. So I've seen a question. I'm going to address your question after we finish. So transmission. So for transmission of rotaviruses, there is direct and indirect. So for direct transmission alone may be sufficient to cause nearly universal infection of the susceptible population. So what we mean by direct transmission is fecal oral, okay? So what happens is, if you get dirty water or let's say poor sanitation or poor hygiene practices, then you get it via fecal oral route. Then indirect transmission can affect the spread of disease through a watershed and may also be sufficient to cause large outbreaks. Direct human-to-human transmission is likely to be more important for local amplification. So you can imagine you have the disease, you present with diarrhea, then I have poor sanitation, and that's how the disease spreads. That's why it causes outbreaks, okay? But they are rare these days because we have vaccines. So that's something you should remember, okay? Then rotavirus disease mechanism. So this is very, very, very important. I want you to pay attention. I want you to pay close attention. So we have ingested the rotavirus particles. They have replicated inside your cells. Now we want to see how they cause disease, okay? Basically, this is the pathophysiology of rotavirus infection. So it causes disease in 3 different ways. Number 1, infection of enterocytes, as we had seen. Okay, let me start with these two because they're the easiest. Enterotoxic activity of NSP4. So NSP4 is it's enterotoxic, meaning that the virus produces it as a form of a toxin. So this NSP4 will go and cause damage to the enterocytes, causing diarrhea. So that's the main cause here is diarrhea. As you can see this flowchart, what you want to cause is diarrhea. Then stimulation of the enteric nervous system. So enteric nervous system is, I don't know if you've done in physiology, but the enteric nervous system is a special type of system. I'm sure you're familiar with the peripheral nervous system and the central nervous system. Now there's the enteric nervous system, which is found in the GI tract. It lines the GI tract. Now what happens is there'll be stimulation of that. And when that happens, when the enteric nervous system is stimulated, there'll be increased secretion of water, electrolytes like sodium, potassium, chloride, bicarb into the lumen of the small intestines or of the bowel in general. And when that happens, what happens is you'll have a lot of fluid in the lumen leading to diarrhea, okay? Then infection of enterocytes. So number 1 is there'll be decreased salt and water absorption. So one thing I want to tell you guys is how rotavirus affects the GI is it decreases the brush border enzymes. So what are brush border enzymes? So brush border enzymes are enzymes that you've heard of, the sucrase, maltase, lactase. So we know sucrase is responsible for breaking down sucrose. Maltase is responsible for breaking down maltose. Lactase is responsible for breaking down lactose. So what happens when these sugars are left unbroken? So will it be osmotic, hyperosmotic, or hypoosmotic? I've been talking for a while. Let me see answers in the chat. Will the lumen of the cell be hyperosmotic, hypoosmotic, or osmotic? I'm seeing different answers. I'm seeing hypo, I'm seeing hyper. So what happens is when the sugar's on the lumen, it will be hyper. Think of it this way. We know that when something is hyposmotic, meaning that there's more solute than solvent. When it is hypo, we know that there's more solvent than solute. If it's osmotic, the level of solvent and solute are equal. So when it's hyper, what will happen is water will be reabsorbed, or basically water will be drawn into the lumen. And when that happens, we'll have diarrhea. Now that is what we call osmotic diarrhea. Okay, so think of that. We have said that The sugars will accumulate in the lumen because of decreased brush border enzymes, the maltase, sucrase, and the lactase. What happens is it becomes hyperosmolar, and when it's hyperosmolar, water will be drawn, because you know water follows solute, isn't it? Solvent follows solute, and when there's a lot of solute, water will follow. And when that happens, you'll have a lot of water in the lumen, leading to osmotic diarrhea. Here, as I said, decreased disaccharide activity and carbohydrate malabsorption. As I mentioned, the decreased brush border enzymes. Ultrastructural changes in the epithelium and decreased surface area. Basically, this is destruction of the epithelium, okay? Then altered gut motility, which makes sense because if you have more water in the gut, food would be able to pass through. So this ultimately leads to decreased fluid absorption because you have a lot of fluid in the lumen, altered electrolyte metabolism. Remember, what is being leaked is not only water, but also, altered enterocyte metabolism, then decreased surface area for absorption, reduced time for absorption, since what happens with diarrhea, peristalsis usually occurs at a very fast rate. And when it occurs at a very fast rate, absorption of nutrients is not possible, okay? Decreased surface area for absorption, since we said that there'll be damage to the epithelium of the intestines. And then altered mucosal immunity, because you're changing the epithelium, the ultrastructural epithelium, okay? Make sense? Now, all this leads to diarrhea. So if you're to summarize the pathophysiology of rotavirus, you'll say it occurs in 3 ways. Number 1, infection of enterocytes. So in infection of enterocytes, what you have to know is that there's decreased brush border enzymes leading to accumulation of sugars, which leads to drawing of water, leading to osmotic diarrhea. Enterotoxic NSP4, which damages the enterocytes, leading to diarrhea. And then stimulation of the enteric nervous system, which causes increase in water, electrolytes into the lumen, leading to diarrhea. Okay, so if you're told to explain this in an essay, like 5 marks, hope you'll be able to do it. Okay, hope it's clear. Signs and symptoms. So from the pathophysiology, let me hide this slide. What can you guys tell me? Tell me the signs and symptoms of rotavirus from the pathogenesis. Diarrhea, yes. Vomiting, yes. Nausea. Remember, if you have no vomiting, you have to have nausea. So nausea and vomiting. Loose stools. So loose stools is diarrhea, yes. Dehydration, yes. We said you're losing a lot of water and a lot of electrolytes. So you'll be very dehydrated. Okay. Fever, yes. We have fever. So since it's an infection, can it lead to septic shock? Yes. So due to the septic shock can occur due to the inflammatory markers that are being released. Yes. Good. I'm seeing you're catching up. So we have inflammation of the stomach, so gastroenteritis, leading to severe diarrhea in infants, watery diarrhea. So you'll notice that this is not bloody. We don't have any invasion into the mucosa, because that's usually the mechanism of bloody diarrhea. There's no invasion of the mucosa. So when you do bacteria, you're going to see that some bacteria such as Shigella, Campylobacter, EHEC, so enterohemorrhagic E. coli or enteroinvasive E. coli. They're the ones that cause blood diarrhea, basically through invasion. And when you invade the mucosa, they're usually blood vessels in the layers of the intestines, that will cause bloody diarrhea. So here, it's basically watery diarrhea. We also have fever, vomiting, leading to severe and life-threatening dehydration. Then viremia. So viremia, when you hear the word viremia, it's usually viruses in blood. If you hear the word bacteremia, that's bacteria in blood. Fungemia, fungi in blood. Okay. Parasitemia, parasites in blood. Okay. Then we have diagnostic and detection. So electron microscopy. So rotaviruses can be detected from stool through electron microscopy. So first of all, before we diagnose, what is the main specimen we need from a patient you suspect has rotavirus? Stool, good. So you can imagine electron microscopy. This is very expensive and it's usually done for research purposes. So this is rarely done on a normal clinical practice. Then enzyme-linked immunosorbent assay, which is ELISA, detection of VP6 group A. So remember the structural proteins we had mentioned, VP6, specific antigen in diarrheal stools by using fluorescent labeled immunoglobulin. Then we have passive particle agglutinin test, also based on antigen-antibody interaction. Polyacrylamide gel electrophoresis, rotaviral double-stranded DNA segments can be detected by electrophoresis on polyacrylamide gel. So all of these are immunological ways of detecting. Then finally, PCR. So PCR for detection of rotavirus in extraintestinal tissues, but also for studying the correlation between disease severity and virus load and the duration of viral shedding in stool. So studying correlation between disease severity and viral load. So the more viruses you have, the more severe the disease is. Okay. So have we understood for detection? Treatment. So one thing you have to remember on treatment of viral enteritis, gastroenteritis, which is rotavirus, is we are not really interested in treating the virus itself, rather we are treating the I've seen someone saying I didn't get the last one. So do you mean the PCR? So reverse transcription PCR. So we've said for detection of rotavirus in extra-intestinal tissues, but also for studying correlation. So basically, I don't know if you've done how PCR works, but here we are interested to see amount of viral load, because in PCR, it will quantify for you the amount of viruses you have. Like, remember we said back here, when we released the virons, there are very, very many. So PCR is able to quantify the amount of viruses that you have. Okay. So if you have more viruses, we expect that the disease will be severe. Okay. Basically, that's how PCR is going to be used in detection of rotavirus. Make sense? Okay. So as I was explaining the treatment, here for rotavirus, we are not really interested in the exact virus because remember, this virus is usually self-limiting. But what we're really interested, our biggest concern is the dehydration. Because these are people, if you leave them untreated, you can be dehydrated, and we know what happens in dehydration. The ultimate goal of dehydration is death. Okay, not goal, but outcome. The ultimate outcome of dehydration is death. So preventing dehydration is the biggest concern. You have to remember that. That is the biggest concern. So oral rehydration therapy is given to prevent dehydration. For children, a rehydration fluid can replace lost minerals more effectively than can water and other liquids. Okay, so the oral rehydration of fluids, basically the difference between ORS and water is that it has certain minerals and electrolytes. So it has sodium chloride at 2.6, potassium chloride, glucose, anhydrous glucose, trisodium citrate, dihydrate. Okay, so we usually give the rehydration therapy and zinc supplementation for acute diarrhea. Okay, so this one you have to remember. It is very relevant. As much as it is relevant in virology, it's also relevant in clinical practice. So if you see, when you start your pediatric rotation next year, you're going to see that patients who have acute diarrhea, we usually give them oral rehydration therapy and zinc supplementation for acute diarrhea. Then probiotics. Probiotics have been shown to reduce the duration of rotavirus, according to European Society for Pediatric Gastroenterology. Effective interventions include administration of specific probiotics such as Lactobacillus rhamnosuroso, I don't know how to pronounce that, Saccharomyces boulardii, and diasome, whatever. Yeah, so basically those are, we call them probiotics. I'm sure you've heard of probiotics from, you'll see yogurt flavored with probiotics. Basically, they come and form normal. They come and form, what do you call the normal flora of our GI system. So I'm seeing someone has asked, what is the use of zinc? So zinc has been shown in studies that it reduces the duration of diarrhea. So this, since it's acute, and from the pathophysiology of rotavirus, we have seen that diarrhea can occur, if left untreated, diarrhea can occur for so many days until the person dies. So it will reduce the duration and also the severity of the diarrhea. And also, one other thing that zinc also does is prevention of future episodes. So it also prevents future episodes of acute diarrhea. Okay. So that's why it's usually it's given with oral rehydration therapy and zinc. Okay. Prevention. Now, this is what I want you have to know. Remember, we said rotavirus is fecal-oral route of transmission. So anything that is fecal-oral, we have to do wastewater management, safe drinking water supplies, so boil your water, have good sanitation, maintain hand hygiene, food hygiene, water hygiene, okay? Because that is how you get the disease. Then vaccination. As I said, rotavirus is not common these days because there is a vaccine. It was developed in 2006. Vaccination is the only control measure likely to have a significant impact on the incidence of severe dehydrating rotavirus disease. 2 new live oral attenuated rotavirus vaccines were licensed in 2006. So we have pentavalent bovine human Rheostat vaccine, Rotatec, and monovalent human rotavirus, Rotarix. So this is what are given to children. So as you can see, vaccination, good hygiene, exclusive breastfeeding, improved water quality. So this is how we are going to prevent. And we know prevention is better than cure, isn't it? Okay. Then for conclusion, worldwide rotavirus is still a significant cause of death in infants and children. Rotavirus affects population in all socioeconomic groups and is equally prevalent in industrialized and developing countries. So difference in sanitation practices or water supplies are not likely to affect the incidence of the infection. So we should create awareness about disease, and proper vaccination program can eradicate this disease. So if you're asked 3 ways of preventing rotavirus, you start with vaccination. Remember, we said health education should be the first point in your mind. So you'll say creating awareness on prevention techniques of rotavirus. Then you say proper waste management, sanitation, proper hygiene, boiling water, and then vaccination. You see, you can reach even 10 points. Okay, I think I'm done. So I saw a question here. I should have answered it at the start. So someone had asked, can you please explain the difference between positive sense RNA and negative sense RNA viruses, as we had said earlier? Okay, so I thought this one you had done well in introduction, but I can just recap. So there's positive sense RNA viruses and negative sense RNA viruses, isn't it? So from the replication cycle of the virus, we know that RNA directly acts as messenger RNA, isn't it? Then what happens is it's translated by the ribosome, then it produces the viral proteins. So for positive sense RNA, that's the pathway it will take. Okay? But for negative sense RNA, it can't be directly translated to the proteins. So what happens is it will need to be copied first into a positive sense RNA by an enzyme called RNA polymerase. I think you've done that in biochem. If you have not, you're going to do it. But for negative sense RNA, what you have to know is it will have to be transformed into positive sense RNA by RNA polymerase. And then if it's transformed into RNA, positive sense RNA, it's going to be translated by the host ribosome into protein, okay? So that's why we call it negative sense RNA and positive sense RNA, okay? Yeah, but that's a good to know point, so it should not really stress you. Is it okay? Sure. So I hope you, unless you have a question on rotavirus, there's some few MCQs I want to show you guys. Okay, question 1. A 6-month-old infant presents to emergency department with a 2-day history of vomiting, watery diarrhea, and fever. The infant has not been eating well and is less active than usual. Physical exam shows sunken eyes, dry mucous membranes, and delayed capillary refill. So the following is most likely cause of the infant's symptoms. So what's the answer? C, rotavirus. Good. So as you can see here, sunken eyes, dry mucous membranes. So basically the dry mucous membranes are the lips, the mucosa, and delayed cap refill. So delayed cap refill is, so what happens, how it's done is you take your fingernail, press on it for 5 seconds, and then you release. If it doesn't refill, okay, so how it works is if you press on it, everyone to do it. I want everyone to do with me. Take your thumb, press it on your other thumb at the fingernail, press it for 5 seconds. So let's do it together. 1, 2, 3, 4, 5. Then release. So blood should gush back to the fingernail. So how long has it taken for you to for the blood to rush back to the fingernail? Comment on your answers in the chat. There's no right or wrong answer, so just comment. Press your fingernail, press for 5 seconds, then release. I'm seeing someone is saying 5 seconds. Okay. Who else? One said immediately. Okay. Immediately. 2 seconds. 1 second. Okay, okay. So that's how we do the cup refill time. So if you text, so the normal cup refill time is immediately to 2 seconds. So if it takes more than 3 seconds, we are thinking of someone is dehydrated, okay? So the patient is dehydrated. So we call it delayed cup refill. Okay, so for the person who had 5 seconds, are you sure it was 5 seconds? Or you're dehydrated? Okay. Yeah. Let's go to the next question. So we have said here it's rotavirus. So E. coli, Escherichia coli, this is a bacteria. Norovirus, we are going to do it, but for norovirus, a specific thing for norovirus is that it's usually endemic in enclosed areas. For example, in cruise ships, barracks. Then Salmonella, this is a bacteria, usually presents with bloody diarrhea. Then Giardia lamblia, which is a parasite, it presents with loose stool. So the diarrhea is watery, yes, but it has fatty stool, okay? And it's usually hard to flush for Giardia lamblia. So here the answer is, someone is asking, what is the significance of sunken eyes? So sunken eyes is a physical examination that shows that you are dehydrated, okay? So sunken eyes, dry mucous membrane, and delayed cup refill. All these 3 physical examinations are signs of dehydration, okay? So so you see the examiner can phrase, or the examiner can tell you the patient seemed dehydrated. So these are the examination findings of dehydration, okay? So pale skin, someone is asking pale skin. So pale skin is not really a sign of dehydration, but a sign of anemia. So meaning that you have low red blood cells, okay? So if you see someone who has pale skin, you don't think of dehydration, you think of anemia, okay? Which of the following is the most likely pathophysiologic mechanism of rotavirus infection? Okay, I want to see your answers. Someone has said A, okay. Any other one? A. Someone has said E, okay. I'm seeing there are different answers. E, okay. One more person. Someone has said B, okay, B. Someone has said D. Good, that was the answer I was looking for. Anzal, very good. And Badri. So, I think I should go back to the slide where, let me go back to this slide. Let me go back to this slide. So, this was the pathophysiology. Seems you guys didn't understand. We said you'll ingest the rotavirus, okay? Then there's infection of the enterocytes. Okay, I started these 2 because they are the easiest to explain. Number 1, enterotoxic activity of NSP4. And when I mentioned NSP4, I was very specific. I did not mention villi, okay? I did not mention the villi. I mentioned the enterocytes themselves. The enterocytes are the cells lining the intestines, not the villi. Here we're not talking about the villi. You know, the villi are those protrusions on the surface of the cells, okay? So if this is a cell, these protrusions that aid in peristalsis, you know, when they waft and move. So we're not talking about that. We're talking about the cell itself, okay? Then stimulation of the enteric nervous system, where we said it's a special nervous system that is found within the bowel that causes increase in water and electrolyte secretion, leading to diarrhea. Then we said infection of the enterocytes. Remember, here's where I said you decrease the brush border enzymes. Do you remember them when I said them? Sucrase, which breaks down sucrose, maltase, which breaks down maltose, lactase, which breaks down lactose. Okay? And when this happens, these sugars accumulate inside the lumen, causing them to draw water into the lumen, leading to diarrhea. Do you remember that? Now, from that explanation, we rule out A, the destruction of the intestinal villi. So we're not destroying the villi, we're destroying the enterocytes. Invasion of intestinal epithelial cells. We said, if anywhere you see the word invasion, to invade means you go inside something. And when you invade the epithelial cells, we expect blood must be produced. And we know that rotavirus is non-bloody or watery. So B is wrong. Activation of adenylate cyclase leading to chloride secretion. So I've not talked about this at all. So as you're going to learn this is the mechanism for cholera. This is how cholera works to cause what we call the rice water diarrhea. Okay, so I've not talked about it. Then choice D, disruption of brush border enzymes in the small intestines. That's the answer. Enterocyte invasion causing dysentery. So dysentery is also another term for bloody diarrhea. So this is, we call it, this is Shigella. This is choice E, and that's a bacteria. And I've not talked about it. So the answer is D. Have you understood? So don't be confused by these big words. But if I have not mentioned it, you should not pick it, okay? Now let's go to the next one. A 7-month-old child is brought to the clinic by her mother due to diarrhea and dehydration. Stool sample reveals no blood or leukocytes. So leukocytes are basically white blood cells. So when you do stool microscopy, there was no blood or white blood cells. The child received her first dose of rotavirus vaccines at 4 months, but missed her follow-up dose. What is the most likely reason the child developed the infection? I'm seeing B. Any other answer? B, okay. Good. So the answer is B. So what happens if you have incomplete vaccination series, you are more likely to get rotavirus. As I had mentioned earlier, rotavirus is very, very, very contagious and it's fecal oral. So if you just have poor hygiene practices and you just got your first dose and you did not finish the dose, you can get rotavirus. So warning, maternal antibodies, what basically choice A means is a decline in the maternal antibodies. So this is not the case. Then antibiotic use. So there's nowhere I've been told the The patient is using antibiotics. Resistance to rotavirus, no. Immunodeficiency, no. So immunodeficiency, maybe if the patient was HIV positive or any other immunodeficiency state that the child was, sorry. Okay, so the answer here is incomplete vaccination series. Okay. A 5-month-old infant presents with vomiting and diarrhea for 2 days. A stool sample is positive for rotavirus antigen. Which of the following is the most appropriate management for this infant? So we have done this. Everyone should be singing the answer. A, good. So we said oral radiation therapy and zinc supplementation. Good. A 12-month-old infant presents with non-bloody diarrhea, vomiting, and fever. Stool analysis reveals rotavirus infection. So the following is the most effective preventative strategy for reducing the incidence of rotavirus infection in infants or in this patient. So remember, the question is asking preventative strategy, not treatment strategy. And then we're looking for the most effective, okay? What's the answer? Excuse me. Excuse me. So I'm seeing, is it A? I don't know if A was the answer for the other question. So answers are starting from here. C, C. Yes. So we said most effective preventative strategy is vaccines. So hand washing, I mean, you can hand wash, but maybe your sewage disposal was bad, or maybe food was contaminated, or maybe, you know, there was an issue with your water. Maybe you boiled it, but not at the right temperature. You see? So the most effective preventative strategy is vaccine. And then why didn't you choose E? Why C? So we know rotavirus is live attenuated, okay? We mentioned an oral inactivated vaccine when we did our last lecture. Do you remember the polio vaccine? There were two types, Salk and Sabin. Do you remember when we mentioned them? So what was Salk? I want you to tell me. Okay, let me frame the question like this. So between Salk and Sabin, which one was live attenuated vaccine? When we did that, was it last week or last week but one? So Sabin was live attenuated. Then which one was inactivated vaccine? Salk. So how I remember is, so the reason it's called inactivated is it is killed, okay? So it's usually inactivated by, you know, things like heat or chemical. So how I used to remember is I say Salk, Salk ends with a K, so killed vaccine or inactivated vaccine. Then Sabin, so Sabin is the live attenuated. So it is live attenuated, meaning it is the live microorganism, but it is non-pathogenic. So basically it cannot cause a disease, but it is the live virus itself, okay? So you remember Salk is killed or inactivated, then Sabin is live attenuated. Okay, next. A 3-year-old child presents to the emergency department with a dehydration due to severe diarrhea and vomiting. A stool sample is positive rotavirus. So the following complication is the child at greatest risk for developing. So this one I have not mentioned. I want to see for those who read. What do you think? What do you guys think? I mean, you might as well guess. If you don't, you have no clue. I put this as a distinction question. I just want to see one answer in the chat. So someone has said A, someone has said C. Someone has said D. I'm waiting for someone to say B or E. Okay, let me end your misery. So, this is a distinction question. So, remember, okay, there's nothing here for you to remember. So, so the answer is B, interception. So, don't worry, this one is just to stimulate your brains. But what interception is basically the intestines come into each other. So basically, let me show you a picture. I don't know how to explain this. Interception. Can you still see my screen? It slides inside an adjacent part. This is what we call interception. Can you see it? That's what we call it. Can you see it? Yes, so this is what we call interception. So there's been some reports that patients who got rotavirus vaccines got interception. Okay? But don't worry, they can't ask you this. This was just as a parting shot. Then I think 2 more questions on rotavirus. A 2-year-old boy is brought to the clinic for evaluation of diarrhea. He has had watery diarrhea for 3 days, associated vomiting and low-grade fever. He attends daycare and his symptoms began after other children in his class became ill. So meaning it is highly contagious. So the following is the primary mode of transmission of the most likely pathogen. So everyone should be singing here. The answer is fecal oral. See, this is why I love virology. It's very direct. If you know something, it becomes very easy. Then the last one, a 4-month-old infant presents the routine vaccination. His mother reports a family history of immunodeficiency in a cousin. The pediatrician considers deferring the rotavirus vaccine. Which of the following conditions would most strongly support deferring or delaying the vaccine in this infant? This is also another question. What do you think? What do you think will make a pediatrician not give a patient a rotavirus vaccine? History of antibiotic use, severe combined immunodeficiency, maternal history of autoimmune disease, family history of celiac disease, asthma in a sibling. Someone has said B. 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 Yes, good. So severe combined immunodeficiency. So this is a type of disease where you have you're at an immunodeficiency state. And remember, the rotavirus vaccine is live attenuated. As much as it does not cause a pathology, it's still a microorganism, a live microorganism, isn't it? Then on top of that, you are immunocompromised or you're immunodeficient. So what happens is this vaccine is most likely going to cause more harm than good, okay? So that's why we don't. So the answer is B. Okay. Do you have any question on rotavirus before we start on rhabdoviridae? Okay. So we're going to do definition, introduction, diagnosis, signs and symptom, prognosis, treatment, and prevention. So why do you think I've put a dog here? I want you guys to tell me. Why do you think I've put a dog when we're talking about rhabdoviridae? It's spread by dog bite. Good. So you know about rabies before we talk about it. Okay. So rabies. So rabies comes from the class, sorry, from the, is it class? No, it's not class. Family. Family, yes, it's called family. Rhabdoviridae family from the genus Lyssavirus, okay? It causes the disease rabies. So the family is called Rhabdoviridae, the disease is called rabies. So rabies is a viral disease that causes acute encephalitis. So from your anatomy, encephal is brain, okay? Then itis is, it means inflammation. So encephal, so brain inflammation, so inflammation of the brain. So it causes acute inflammation of the brain in warm-blooded animals. So warm-blooded animals are mammals, birds, and well, just those two, mammals and birds. Then reptiles, amphibians, and fish are cold-blooded. So rabies is a zoonotic disease. So zoonotic means it's transmitted from humans to animals, and it's caused by the rhabdoviridae. So here is the rhabdoviridae or the rabies virus. One thing you have to note is it is bullet-shaped. We said, which virus have we done? We have done rotavirus, and it said rotavirus is circular. This one is bullet-shaped. Can you see it? So if you were to label it, you can see the matrix protein. So let me show you. Can you see this? This is a matrix protein. Then we have the RNA, genome, helical coli. These are the RNA polymerase. Okay. Phosphoproteins. Here they are. Then the lipid membrane, and then covered by glycoprotein. So from the outside you have glycoprotein, which forms the envelope. So the envelope is the one that's the covering, and the host-derived lipid membrane here. And then the inside is the matrix protein. Then we have the nucleoprotein, phosphoprotein, and the RNA polymerase. Okay. Okay, so let's introduce. So we said it's bullet-shaped, as you can see. The disease infects domestic and wild animals and is spread to people through close contact with infected saliva via bites or scratches. Okay. Dog bites, dog scratches. Dogs are the source of 99% of human rabies deaths. Then one thing you have to remember with rabies, once symptoms of the disease develop, rabies is nearly always fatal. Then you have to remember. You have to remember. Okay? So here's a dog. So these are also other reservoirs. We have dogs. This is a bat. Pigs, cattle, donkey, monkey, horse. What is this? This is a bat. What animal is this? Who knows what animal this is? Coyote. It looks like a coyote. It's a mongoose. We heard of mongoose. Yeah, so those are other reservoirs apart from the dogs. So I will kill you. So this animal can kill you. Beware. This cute puppy can kill you. So someone saying, I had a near-death experience with a rabies-infected dog. Oh no, so sorry to hear that. I'd love to hear the story, maybe after we finish. Okay, so source of infection. The source of infection to man is the saliva of the rabid dog, of the animals. In dogs and cats, the virus may be present in the saliva for 3 to 4 days before the clinical onset and during the course of illness till death. Okay. So, okay. So, cause 90% of human cases is the dogs come from cats. We said you can have the mongoose, all those bats, they can be the reservoirs. Okay, incubation period. We see also foxes. It is highly variable in men, commonly in man, commonly 3 to 8 weeks following exposure. The closer the bite is to the brain, the shorter the incubation. So this is something you have to remember. What this means is, if a rabid dog bites me on the arm, let's say on my forearm, and it bites my friend on the neck, we'll have a shorter incubation. Is it me who was bit on the forearm or my friend who was bit on the neck? My friend, yes. Because I've said, the closer it is to the brain, the shorter the incubation. Rabies travels 1 centimeter per day. So I'll show you how it travels so that this sentence makes sense. So here's a rabbit dog, rabbit bat, eared fox. You can see this fox. This is another rabbit dog. So funny thing is, these dogs, they get bit by things like bats. Then these dogs will give you, or raccoons, skunks, foxes. Okay. So let's start with this. So how it spreads. So you'll be bit here. The farther away from the brain, the longer the virus takes to spread. Okay. I'll come to this slide. Let me start with this one first. So this is how it starts. Virus enters via animal bite. Let's say it bites you here. So it tears the skin, enters into the epithelium, enters into the muscle. Virus replicates into the muscle at the site of the bite. You have to remember that. Okay. At the site of the bite, the virus starts replicating. So the virus infects the nerves in the peripheral nervous system. So do you remember the nervous system? There's the peripheral nervous system, which are these nerves, and the central nervous system, which is the brain and the spinal cord. So anything that's not the brain and the spinal cord becomes the peripheral nervous system, and it moves by retrograde transport. So the nerves come going down, but the virus goes vice versa. So that's why we call it retrograde transport. It follows the nerve going up, but we know that signals are sent from the nerves going down like this. So retrograde transport. Then the virus replicates in the dorsal root ganglion. So you remember here the spinal cord. So before we reach there, there's the dorsal root ganglion. It will also replicate there. And then it travels up the spinal cord to the brain. When it reaches the brain becomes infected. Now here is where you start getting the symptoms. After getting these symptoms, we said that fatality is almost 100%. So the virus then travels from the brain via the nerves. But now this time, when it's traveling from the brain to the nerves, it's anterograde transport. So it is going like this, following the nerves. So to the eye, the kidney, the salivary glands. Okay, so have you understood? We start with entering via the human bite, replicating at the muscle, retrograde transport, replicate at the dorsal root ganglion, travel up the spinal cord to the brain, then from the brain, it goes to the other nerves. So anterograde transport to the other tissues like the eye, kidney, and salivary glands. So here it is, live virus, epidermis, then mucous membrane, goes to the peripheral nerve, centripetally, to the CNS. Basically, this is going towards, and then when it reaches the CNS, which is the brain and the spinal cord, centrifugally, meaning away to other tissues like the salivary glands. Okay, have you seen that? Okay, so here are the signs and symptoms. Basically, this was a summary of everything. Infected animals show no fear for humans, act very agitated. Bird, fox, cat, skunk, dog. So let's start with the bizarre behavior. So bizarre behavior is they'll start throwing up their arms, they'll be very agitated, they'll, someone who is just bizarre, like they act in a very bizarre way. So this is when the virus has reached the brain. Agitation, seizures. So this is where it has reached the brain. Now, difficulty in drinking is now when it has reached the muscles of the involved in drinking, at the pharynx level. So what happens is they usually have hydrophobia. So you should ask yourself, why do they have hydrophobia? So as you can see here, I've written, even the sight or sound of water disturbs the patient. I think I should show you a video where if they see water or even hear about water, they start getting spasms. So they'll start, in Kiswahili, they call it povu. I don't know if I zoom here. It's foam. They call it povu. So this is the foam they usually get. So this is caused by spasm of the muscles. So what happens is they have laryngeal spasms, and then they also have diaphragmatic spasm, okay? That's why they release this foam. This is basically saliva, okay? Then when this happens, they can get sensations of asphyxia. Asphyxia is basically choking. So they'll tell you that they have hydrophobia. They won't tell you, you will see that they have hydrophobia, the fear of water, but they suffer with intense thirst. Spasms of the pharynx produces choking. Death can occur in 1 to 6 days. Respiratory arrest, death, some may survive. So surviving, I was reading, there was one case where someone survived rabies. What happened is the doctor put them in an induced coma. It's called a hypothermic induced coma, where they reduce the temperature of your body to less than the normal temperature, and they let the immune system to fight off the rabies. And basically they survived, but this is very rare. As we said, mortality is almost close to 100% after symptoms proceed, after the symptoms show, okay? So respiratory arrest can occur, then death. So we also have headache, fever, sore throat. So these are called the prodromal symptoms that occur before. These are the worst symptoms. These ones occur before. Pain and tingling at the site of the bite, hallucinations. So this is when the virus reaches the brain. Hallucinations is seeing things that are not there. So it can be visual hallucinations where you're seeing things that are not there. It can be auditory hallucinations where you're hearing things that are not there. Tactile hallucinations where you're feeling like someone is touching you and it does not exist, okay? So hallucinations can occur in all the 5 senses. Then hydrophobia, which we've said is the fear of water due to spasm of the throat. Paralysis, okay? Since the virus is ascending through the nervous system. So, and we know that the nerves are the ones that innervate the muscles, and the nerves are not, when the nerves are affected, you can become paralyzed. Then you get into a coma, and then you finally die, okay? So this is the picture showing the brain inflammation. Then this is the bite by this fox. You can see, so you'll first start with pain here, then it will rise like that, like that. Let's go back to our summary. So fever, depression, agitation, painful spasm followed by excessive saliva, foaming at the mouth after drinking, produced by spasm in the throat, death within a week without vaccine. Then treatment you're going to see. Okay, so you can see here the bite marks. Here, this looks like a scratch mark, then this looks like a bite mark. So you start with pain here, okay? Yeah. Prevention. Now, if you weren't paying attention, now I want you to pay attention. There are 2 types of prevention. We have pre-exposure prophylaxis and post-exposure prophylaxis. So this is known as PrEP, and this is known as PEP. So pre-exposure prophylaxis, what does that mean? You get the vaccine before an event. Then post-exposure is after the event, basically after the bite. So let's start with pre-exposure vaccination. So here they are. We start with vaccinating the dogs. So these are ways of preventing. You have to vaccinate these dogs against rabies, vaccinating cats, or you can't vaccinate you can't vaccinate wild animals. Like you can imagine vaccinating a fox. It's not possible unless you want to keep a fox as a pet, but we're interested in our dogs. Okay, is the vaccine. And then we have people who work with these animals. So provided to subjects at risk before occupational or vocational exposure to rabies. So these people are like veterinarians, cavers, you know. So these are the people we give them pre-exposure prophylaxis, because you have to give a veterinary doctor, since they can be exposed to rabid dogs or cavers. People who go doing hiking, caving, they can meet bats there. Then it also simplifies its post-exposure management. Okay, so you can imagine if you already had the pre-exposure prophylaxis or post-exposure. So in case you're bitten, it will simplify the management. Okay, then we go to post-exposure prophylaxis provided to subjects after rabies exposure. So this is if someone is bit. This lady, you can see after she was bit. So it consists of 3 things. Number 1, good wound care, rabies immunoglobulin, and a vaccine. Okay, let me show you good wound care. Let's start with good wound care. So after bitten, wash the area of the animal bite thoroughly. Ideally, you should use sterile water. If not, you just use warm water and soap for 15 minutes. Okay. Initial treatment for animal bite should include thorough cleaning. However, all animal bites should be seen by a physician. So as you're waiting to go see a doctor, proper cleaning for 15 minutes with water and soap. Then if there's active bleeding, remember you apply pressure to prevent excess blood loss. Okay. Okay, so that's the wound cleaning part. Then the rabies immunoglobulin. Here it is. So there are 2 human rabies immunoglobulins that are available. both supplied in vials at 150 international units per ml. Okay, so have you heard of immunoglobulins? So there's IgG, IgM, IgE, IgD. Those are the immunoglobulins. Okay. Basically, they're antibodies. So, okay. And then we have the vaccine, which is the post-exposure vaccine. So we start with cleansing, then chemical treatment, suturing. So suturing is closure of the wound. What do you think? After you've been bit by a dog, do you think you should close the wound or you should leave the wound open? I want to hear your thoughts. Let's go to this wound. It's not such a deep wound, but imagine if it were a deeper wound. Should we close it or leave it open? Someone is saying close. Any other opinion? Close to prevent further entry of infections. Okay, I like your reasoning. Any other opinion? Close, close. So everyone is saying close. Funny thing is, we don't usually close the wounds. So let me explain why we don't close. So after doing proper wound care and giving them the vaccines, remember, this animal, as much as yes, it might have rabies, it also has other microorganisms. So in the bite, if you were to take a sample of this, let's say we take cotton wool swab and we go culture, you might find bacteria, you might find fungi, you might find viruses, you might find, all sorts of microorganisms in this wound. So what happens is we don't close. So you can imagine you've given them the rabies vaccine and then you close the wound. After closing, imagine you have closed the bacteria that was here. So what will happen? The bacteria will go to seep to blood, get bacteremia, then you can get sepsis and you die just because you closed the wound. So we avoid closing, okay? And then for people who have been bitten, we have to give them antibiotics, as I said. So the antibiotics is to cover the bacteria and anti-tetanus measures. So, okay, you learn this. I'm sure you've heard of tetanus. So tetanus is a type of bacteria. Okay. So anti-tetanus. So you give them anti-tetanus and antibiotics. Someone's asking, is in suturing closing? Yes. So suturing is closing. So suturing is closing, but I've said that we don't close. Okay. Yeah, as I think I had written here. Yeah. I think avoid suturing wounds. Okay. Okay. So I'd put here for you to think about it. We do not suture. Okay. Observe the animal for 10 days. Okay. Wash lesions well with soap and water. This is also a tetanus booster. So you can see here, infiltrate rabies immunoglobulins, 20 international units per kg into and around the margin of the bites. So here, and into and around the margins. Administer vaccines on days 0, 3, 7, 14, and 28, then possibly the 90th day. So after 3 months. So as I had mentioned, the immunoglobulin, I had explained the wound cleaning. So this is how it looks like. Cynosoccer. So this is the brand Cynosos for the rabies immunoglobulin. So treatment. So post-exposure treatment, local wound treatment, as we had said, wash with soap or detergent for water, preferably for 10. So 10 to 15 minutes. Apply alcohol povidone, iodine, or any antiseptic. So these are antiseptics. Make sure you give antitetanus. Then also an antibiotic to cover for the bacteria. Avoid suturing wounds, as I had explained. Then don't apply ointment, cream, or wound dressing. So you leave the wound open, okay? Then here are the types of antibiotics you give. So don't worry about the names. You'll be taught in pharmacology. So we have amoxicillin, fluoxacillin, and cefuroxime. So for those instances, there is no obvious sign of infection, amoxicillin as prophylaxis. Okay. So by the time you use cefuroxime, it's a very strong antibiotic. So we just use amoxicillin for prophylaxis if there's no obvious signs of infection. So signs of infections are things like fever, pain, things like that. So educate the public on local wound treatment and warn not to use procedures that may further contaminate the wounds. So this is on health education. Remember, we said in any virus or bacteria, health education should be your number 1 point. Then vaccine administration. This is just for you to know. There's intramuscular schedules. So I'm sure our friend will tell us how he was given the vaccines. Six doses schedule. Then there's intradermal. So intramuscular means you're going inside the muscle. Intradermal is at the dermis. So it's not at a 90-degree angle. You slightly tilt it to like 45. Then we have days of immunization, day 0, 3, 7, 28. Here at the site, at the deltoid. Deltoids is greater than 2-year-olds and adults, then anterolateral thighs for infants. And here it is. Then we have for management of rabies patients. So we said once the symptom starts, treatment should center on comfort care using sedation, avoidance of intubation, and life support measures once diagnosis is certain. So remember, we said once the symptoms start, we know that mortality is almost 100%. So it's all about comfort care. Okay, so there's so much you can do. But the good thing is, I think I had written it. Okay, the good thing is between time of being bit and symptoms onset, it's a very long time, depending on where you are bit, isn't it? We said the closer you are to the brain, the more immediate the symptoms will be seen. So once you're bitten, rush to the hospital. You'll be given post-exposure prophylaxis, and you'll be okay. Okay. So that's why deaths due to rabies are not that common, unless you have no clue at all. You were bitten and you just sat down at home. Then you got the medication. So here are the medications: diazepam, midazolam, haloperidol. So don't worry about the big names. Diazepam, midazolam, haloperidol, these are used for sedation. Remember, we said the patients can be highly agitated and very bizarre, to have very bizarre behavior. So these are the medications we give them to sedate them. Then supportive care. Patients with confirmed rabies should receive adequate sedation and comfort care in an appropriate medical facility. Once rabies diagnosis has been confirmed, invasive procedure must be avoided. So, I mean, prognosis is usually poor, so we just provide suitable emotional and physical support, discuss and provide important information to relatives concerning transmission of the dose, indication of PET, of contacts. Honest, gentle communication concerning prognosis should be provided to relatives of the patients. Yeah, so it's all about supportive as you await for them to die, unfortunately. Patients should be admitted in a quiet, draft-free isolation room. Healthcare workers and relatives in contact with patients should wear proper personal protective equipment, gown, gloves, and masks. And then finally, it's not about if, it's when they die, you dispose the dead bodies properly. Okay. So you're not prolonging their lives, but you're just giving them a good life. So you sedate them and maybe visit them as you wait for them to die. Yes. So you've seen how rabies is serious. Do you have a question?
Hi, I have a question.
Yes.
Can you hear me? So why can't we give the why can't we vaccinate everyone um before like we wait for someone to get bitten?
So first of all, so what's your name?
Navya.
Oh, hi Navya. So first of all, one is you look at for you to do that, you're trying to see, is rabies a problem or is it endemic in your region? So maybe if you were to do a proper research and see, let's use Nairobi at Chiromo. Maybe there was one rabies incident during the year, just one. So is it feasible to vaccinate everyone who stays in Chiromo?
No.
It's not feasible. So it can get expensive and a waste of resources. Okay. But in an endemic place, so that's why we vaccinate, as I had said, as I had mentioned here, people who are exposed to these animals. For example, veterinary doctors and people who do hiking and caving maybe as a hobby or as a career. These are people who are vaccinated because we know that they will be exposed in the long run. But otherwise, it's not that important to do so. And then another thing is, we know that we have said the incubation period for rabies is long, depending on where you've been bitten. So these are people who can get the post-exposure prophylaxis. Okay.
Yeah, thank you.
Okay. Any other question? Maybe one thing I can mention is here, after disposing the dead bodies. So when you do autopsies of these dead bodies, there's something specific you're going to see under histology. So there's something called Negri bodies. Okay. So Negri bodies, let me see if I have a picture. Minute. Can you see this? Can you see my slide? So this is what we call Negri bodies. So these are things that are found on autopsy. So what are Negri bodies? So Negri bodies are eosinophilic aggregates. Okay. So these are the proteins that were found in the rabies vaccine, they're the viral proteins, the rabies proteins. So they have stained them and you're going to see them. So this is basically a neuron and this is the cytoplasm of the neuron. So this is the Negri body. So those are the things you're going to find in autopsy. A neuron showing a cytoplasmic inclusion body, a Negri body. Okay. That's what we call the postmortem finding of rabies. Okay, so let me share these questions with you guys. Okay, so we start. A 10-year-old boy is brought to the emergency department after being bitten by a bat while hiking. The bat flew away. It could not have captured for testing. Which of the following organisms is most likely responsible for the potential infection? Rhabdovirus, Lyssavirus, coronavirus, arenavirus, flavivirus. Answers? Rhabdoviridae, isn't it? Good. So the following is the most common mode of rabies transmission. Aerosolized droplets from infected animal, ingestion of contaminated food, bite or scratch from infected animal, blood transfusion, contact with contaminated surfaces. Bite or scratch from infected animal. Good. Which of the following best explains the pathophysiology of rabies? So we start virus replication in blood followed by systemic viremia. Virus replication in muscle at the bite site followed by retrograde axonal transport to the CNS. Direct invasion of the CNS through hematogenous spread. Immune complex deposition in the brain. Progressive demyelination of peripheral nerves. B, good. Remember when I explained the pathophysiology? So it will replicate at the muscle, then retrograde transport to the CNS, then anterograde to other tissues. A 7-year-old girl was brought to the clinic after a raccoon bite. Her parents are concerned about rabies, but the girl is asymptomatic. So the following is the incubation period for rabies in humans. What's the incubation period of rabies? Answers? Someone is saying C, others are saying B, 1 to 3 weeks, 1 to 3 weeks. Any other answer? B. So, I don't think I had mentioned this, but the incubation period of rabies is 4 to 12 weeks. Okay? So the answer should be C, 1 to 3 months. Okay? You see how long the incubation period is. So when you beat, shouldn't wait. As much as you have a long time, you should not wait. Okay? So these are the factors that make post-exposure prophylaxis to thrive due to its long incubation period. Okay? A 45-year-old man is admitted with hallucinations, hydrophobia, and hypersalivation. So hypersalivation means increase in saliva secretion. He reports being bitten by a wild dog 1 month ago, but did not seek medical attention at the time. So the following is a characteristic clinical feature of the above disease: ascending paralysis, painless genital ulcers, photophobia, agitation altering with periods of calm, seizure activity triggered by loud noises. A seizure is involuntary twitching. People call it convulsion. Answers? D. Good. Agitation, alternating with periods of calm. Okay. So why is E wrong? Triggered by loud noises. Okay. So their seizures are not attributable to noise. Okay. A 60-year-old man presents the emergency department with altered mental status and hypersalivation. He was recently bitten by a bat but did not receive treatment. A lumbar puncture is performed, which of the following diagnostic tests is most commonly used in antemortem diagnosis of rabies. So antemortem is the opposite of postmortem. So what tests are used in the diagnosis of rabies when someone is alive? That's what the question means. I did not mention this, so this is if you read. C. Any other answer? Any other answer? C. Okay. So reverse transcriptase PCR of saliva, skin, or CSF. Okay. So in saliva and CSF, we are going to find the viral RNA. And then on the skin, we'll find the antigens against the rabies virus. Okay, so C. Then number 7, a 30-year-old woman is brought to the hospital after an animal bite from a stray dog in an area endemic for rabies. Despite rapid intervention, she dies 2 weeks later. So the following is the most characteristic finding in the postmortem diagnosis of rabies. So this one we mentioned. What will you find? I'm saying varied answers. I'm saying A. I'm saying D. So everyone has decided it's D. So Negri bodies in the cytoplasm of hippocampal neurons. So yes, that's the answer. A. Eosinophilic inclusion bodies in neurons. So we are very specific in the neurons. So we said Negri bodies are eosinophilic inclusion bodies. Yes. They're the aggregates of the viral proteins, isn't it? And they're found in the cytoplasm of the neurons. But this is too vague. You don't expect them you don't expect to find them in the peripheral nervous system neurons. So we expect them to find in the brain. Okay, so that's why D is the answer. Then number 8, I think this is the last question. Or number 9 and 10. Oh, still more. Number 8. 20-year-old man presents after being bitten by a stray dog. He has no history of prior rabies vaccination. The wound is cleaned thoroughly and is started on PEP. So the following is the correct regimen for PEP. So it's D, okay? So you'll go check from the regimens for PEP. So rabies immune globulin and 4 doses of rabies vaccine, 0, 3, 7, and 14, okay? Then this is the question he is asking, regimen for PrEP. So here it's 3 doses of rabies vaccine on 0, 7, 21, and 28, okay? You'll notice in PEP, we have to give the rabies immunoglobulin and the rabies vaccine. But in PrEP, we only give rabies vaccine. We don't give rabies immunoglobulin or PrEP. So PrEP is before exposure. And then here it's asking the most important first step in management of potential rabies exposure. What is the first step? B, good. Clean the wound thoroughly with soap and water for at least 10 minutes. 42-year-old man receives PEP or rabies following a dog bite 3 weeks ago and is still concerned about the risk of infection. Should the following best explain why post-exposure prophylaxis is highly effective in administering if administered correctly? Yes. I think I had mentioned this. Okay, good. So the long incubation period, which is 1 to 3 months of the rabies, allows time for vaccine-induced immunity. So that's why PEP is very effective. Then finally, 19-year-old hiker is bitten by a raccoon while camping. He started on rabies post-exposure prophylaxis. Which one best describes rabies? First of all, we have to know it's RNA. So choice A is wrong. So it's RNA. Is it double-stranded, positive sense, or single-stranded, or negative sense? I think this is the last question, yeah. Hmm? Excuse me. Negative. Yes, so it's negative sense, single-stranded RNA. Yes, and I think with that we can finish unless you have a question. Thank you very much. See
I
you.
have a question.
Oh, okay, sorry. Yeah.
Um, let's say if like someone is bit and then let's say if it's the hand, then can we like amputate the hand? Do you think that's going to help, like this, to prevent the spread of the virus?
Wow, I mean that's such a drastic measure. Um,
Um,
you're asking if it's possible or if it's a viable option.
if it's a viable option.
I mean, who would want their hand to be amputated?
But I mean, it's better than it spreading to the brain and you're gonna die anyways.
Yeah, but I mean, there are other better ways than amputation of the arm. The vaccine,
Okay.
I mean, the post-exposure vaccines work.
Yeah.
Yeah. So, amputation, not really. So, what you're going to see,
Um,
um,
yeah.
for amputation, um, what I know in amputation, if you were to focus on microbiology, there's some certain microorganisms that affect a limb, solely a limb. So it will cause something called necrosis and then the death of that limb. So amputation is only viable if the limb no longer functions and if you want to prevent, spread of the microorganism to other parts of the body. So that's when we amputate. So for example, in like snake bites or certain bacteria where you get necrosis, let me show you. So it's called gangrene. Let me show you a foot. So if you see a foot like this, so we amputate this foot because it's no longer living. Okay. But
Yeah.
for rabies, no, we don't.
Okay. Thank you.
Okay. Any other question?